Alrighty, everyone, thank you so much for your patience. Let's go ahead and get started. If you haven't already signed in, please do so. I can post the link in the chat later. So let's begin. So I know this exam is a little bit all over the place, but we're going to break it down bit by bit. Like I said earlier, our first portion is just going to be a good content review. And then I do have a 40-question Kahoot for those that wish to play that can play at the end. So we're going to go ahead and get started with our chronic GI disorders. The first thing we're going to talk about today is going to be our peptic ulcer disease. So what in the world is peptic ulcer disease? It can be caused by a lot of different things, but usually what we're seeing the most is either frequent NSAID use or an H. pylori infection. Now, it's really important to know what the cause is because this is going to help us dictate what treatment is going to be. And we'll talk about that when we get to our next slide. But essentially what's happening is that something is causing erosion along the GI tract. And that's a really big issue because as you can see, it can lead to perforations, hemorrhages, anemias, dumping syndrome, etc. So it's really, really important that we address the underlying cause and that we're doing thorough assessments for these complications. If at any point you notice a rigid board-like abdomen, we know that there's a really big issue. So how in the world do we differentiate between gastric versus duodenal ulcers? Well, it's all about knowing where the GI tract is being affected. So we have our duodenum, think delayed. Duodenum sits below kind of the stomach area. With our gastric ulcers, this is kind of like our upper GI tract. So if someone has a gastric ulcer, it's simply up higher along the GI tract. Therefore, we're going to see those signs and symptoms a lot quicker. That is why pain is worse right after eating, which leads to malnourishment because they eat, they have a lot of pain, and they don't want to eat anymore. If someone has a duodenal ulcer, we're not going to see that malnourishment because it's not really affecting their meal times. In fact, what's interesting about your duodenal ulcers is that pain is actually relieved with eating. So based on the cause, we really need to make sure we get an EGD done. We get our urea breath test. This helps us know if the cause is an H. pylori infection. So what in the world are we going to do if they have an H. pylori infection? We are going to do our 2+1. So we're going to usually put these patients on 2 antibiotics, your ciprofloxacin, your ampicillin, whichever it may be, plus a proton pump inhibitor, a prazole. So that is what we do if it is an H. pylori infection. Additionally, lots of our GI meds are going to help, and possible surgery. So as nurses, when we're doing our thorough GI assessments on these patients, we're also going to kind of be aware of the fact that these ulcers can perforate and bleed. A lot of our focus is also going to be on patient education, teaching them what they need to avoid. You'll kind of see this throughout my review, but a big overarching theme of our GI interventions is going to be an upper GI series with contrast. This gives us a picture of what is actually happening, where these ulcers may be, etc. But a big nursing consideration for all of our upper GI series with contrast, whether it be that or a barium swallow study, is that these patients have to be NPO prior, and that after we need to flush out the contrast dye because it is very, very toxic. So what are we going to do? We're going to push IV fluids, and we are going to give them actually a laxative that works very, very quickly to try to get this out. GERD, on the other hand, this is an LES issue, lower esophageal sphincter issue. So essentially, think of the phrase down the hatchet. Well, what happens when the hatchet keeps opening and closing and opening and closing? It's not going to stay down the hatchet, and that's all that's happening with GERD, is that we've got this reflux up into the esophagus, and they're having all this acid and little baby vomit kind of going back in their mouth, which can over time erode the throat. Why is this a concern? Well, when we have erosion, we have cell tissue changes. What do we know about these changes? People that have like cell dysplasias are at increased risk for developing cancer of the area, and that's what we call Barrett's epithelium. With these patients, they're going to have lots of heartburn, and everything is worse when they're lying down. Why? Because that when you're lying down, your LES is already loose. So we have something that doesn't work very well, and then by lying them down, we make it 10 times worse. Okay, so how in the world are we going to teach them to kind of modify this? It's diet and lifestyle modifications. No fried fatty foods. Please sit upright after eating. Why don't we want them eating late at night? Because what do I do late at night? I go to sleep, okay? Right now it's been around 2, 3 a.m., but you don't see me trying to eat something at 1 a.m. because I know that it's not going to be too good. In the event where surgery becomes an option, we can do a fundoplication, but there are risks associated with that. That's why we focus more on our patient education. And like I said, if they're getting a GI series, we need to give them a laxative and we need to flush with fluids. That's the nursing role of a lot of these things. And you'll see this trend of what's the role of the nurse in a GI issue. It's going to focus heavily on patient education, assessing for emergencies, and knowing how to prep pre-op, post-op procedure. Okay. IBS, this is irritable bowel syndrome, not to be confused with irritable bowel disease. So essentially with IBS, we have this kind of alternation between diarrhea and constipation, and really the GI system's kind of just going a little bit out of whack. And how do we diagnose it? They have to have this recurrent pain for at least 3 days a month within the past 3 months. And usually this pain gets relieved when you move the bowel, and that's not limited to surgery. Sometimes kind of pushing on these patients helps a little bit too. Okay. Another thing that we kind of need to keep in mind when we are caring for these patients really is what is our big priority concern? Well, if my patient is having tons of diarrhea, I'm concerned that there's going to be some fluid electrolyte imbalances, maybe some hypokalemia, hyponatremia, massive dehydration, or if they're constipated, I'm a little bit concerned for a possible bowel obstruction. That's why it's really important we're going to be auscultating and doing all of our important assessments. We treat based on what's going on. You have IBS with diarrhea, we're going to give you antidiarrheals. And it's important to note that a lot of a couple of the IBS meds can only be used for women. So alosedron only used in women for severe diarrhea. When we have IBS constipation, you have your lubiprostone, again, only works in women, okay? But essentially, like all of our GI stuff, it's going to focus heavily on your patient education, removing your triggerers, increasing fluid, fibers, fruits for constipation, etc. So now, straying away from IBS, now we're going to talk about IBD. When we have IBD, think you've got IBD up at the top, and it separates into 2 categories, Crohn's versus ulcerative colitis. So I'd like to kind of start this. How in the world are they similar? Well, number one, they're both autoimmune. And what do we know about every autoimmune disorder? Well, we treat it by suppressing the immune system. That's a good way to do that. But also, we will have flare-ups in times of stress. The stress puts the body at risk for infection. We know it's an autoimmune, so they're going to have exacerbations during times of stress. Remember, I'll say it all day, the body doesn't know stress from this upcoming exam versus physical stress versus I'm stressed because, I'm not been sleeping. The body doesn't know how to differentiate, essentially, which can make it really, really difficult. And that's why a lot of our patient education is going to be around how to stay in sort of a remission. Now, this begs the question, how are they different? When you think of ulcerative colitis, I want you to think of colon. This is usually limited to the colon. Usually our large intestine kind of leading to the rectum, and we have a pinpoint area. Additionally, when you think ulcers, think blood, So these patients have bloody stools. With Crohn's disease, I want you to think of patches. We have patches of inflammation everywhere. It's more inflammatory as opposed to ulcers, so that's why we usually will not see blood in the stool. Okay, so let's talk about ulcerative colitis first. Again, your hallmark signs and symptoms of all IBD, whether it be Crohn's or UC, is going to be frequent stools with crampy abdominal pain, categorized by exacerbations and remissions. So someone with ulcerative colitis, this is kind of more limited to the colon and rectum, which is why we actually see a lot more frequent stools. 10 to 12, that's a lot of stools. And they're bloody too, because we've got that ulcer component, which is not very fun for these patients. So what are we going to look for in labs? We're going to look for fecal occult. We are going to watch their hemoglobin and hematocrit, because you might have a patient that simply with UC is just bleeding so much they might need like a PRBC infusion, simply because they're losing that much blood in the stool. Okay. What can we do? We love steroids for autoimmune disorders. Those help very well. NSAIDs are actually very good at helping to maintain remission, which is very interesting. And what is a good treatment choice for ulcerative colitis? We can actually place an ileostomy on these patients. Now, why in the world can we do that? Because with ulcerative colitis, it is limited to a certain part of your GI tract, usually your colon or your rectum. And the thing about this is that we can excise that portion out, or we can remove that portion, because why? We can definitively identify here's where the problem area is. So I can either cut it out and try to sew the two ends together, or I can cut it out and place an ileostomy bag. Okay. So please just keep that in mind, that with ulcerative colitis, we can opt for an ileostomy. And honestly, these patients might just prefer an ileostomy as opposed to a life on immunosuppressants and having just this really big GI issue that they do have. Again, nursing interventions, if we need to get a visual picture of what's going on, we keep the patient NPO and prep for a contrast. Okay. Really, really, really want you guys to be concerned about UC. Not only we have a bleeding issue, but 10 to 12 stools is a lot. They can lose a lot of fluid, a lot of electrolytes. So watch for those signs and symptoms of dehydration, those dry mucous membranes, poor skin turgor, all of those very important things. Up next, we have Crohn's. I want you to think inflammation everywhere, from the mouth to the bottom, okay? This is why an ileostomy is simply not going to work for these patients. Now, why in the world is it not going to work for these patients? Because if I were to cut out every problem area, I would have probably about 27 ileostomies placed on this patient, and we probably would just remove the entire GI tract, if I'm being completely honest. That is why we're going to focus more on med management. Okay. This also penetrates through all the walls of the intestines, which leads to more of a malabsorption issue, which is why usually our Crohn's patients are a lot more emaciated. They are a lot more likely to be underweight, malnourished, low albumin levels, all the sorts, because it's going through all the layers and we're having a poor absorption problem, where we don't really see absorption being an issue in ulcerative colitis. Okay. Like I said, surgery with an ileostomy is not going to work for these patients. Additionally, Crohn's, you've got all these problem areas throughout the intestinal tract. It can cause strictures. So a lot of these patients, the only surgical intervention is going to be stricture relief. Okay. Unfortunately for Crohn's, there's not much you can do to treat it aside from your traditional immunosuppressants, but we can educate these patients on low fiber diets. Okay. Usually we teach high fiber for heart health and it helps you have regular bowel movements, but for patients that are having 6 to 7 bowel movements a day, they don't need to be doing anything that can further make it an issue. Additionally, when a Crohn's patient is in a massive flare-up, we're probably going to want to keep them NPO and do some sort of enteral nutrition to really give the GI tract a rest, the bowels a rest, things like that, in times of acute exacerbations. Similar on the track of tummy stuff, if you will, we're going to talk about hiatal hernias. So we have a couple of different types of hiatal hernias, but all I want you guys to really understand is that different parts of our, whether it be the esophagus, whether it be the duodenum, whether it be the stomach, is outpouching somewhere where it shouldn't be, or it's getting pushed somewhere it doesn't want to be pushed. And what can that cause? It can cause lots of heartburn, lots of dyspepsia, lots of suffocating chest feeling. So again, I wouldn't stress to know the exact differences between the two, but just know that these patients present similarly to patients with with just regular heartburn and GERD. So it's important for us to really get a barium swallow study with fluoroscopy so we can see what's going on. And that's kind of like the circle of GI, where a lot of it's just like we just need to visualize what's going on in order to diagnose it. Okay. And the only way to do that is with your GI study with contrast. Okay. Our major complications is going to be a volvulus. What happens when things get squeezed and squished and get shoved into areas they don't want to get shoved into? We can potentially cut off blood flow, and that is a problem. So what in the world can we do for these patients? They have a lot of dyspepsia. Well, let's give them some stuff to neutralize the acid so it's not such a big deal. You can also do a fundoplication for this procedure, or for this pathology, if you will. Please note the proper post-procedure protocol for someone that had a fundoplication. After surgery, they need to be on a clear liquid diet, no straws. You'll actually see a lot of nurses write on the some hospitals have whiteboards above the patient's bed where they can write no blood pressure in left arm, no IV sticks in left arm, because that might be where a fistula is, or a woman had a mastectomy, something like that. But you can also write no straws. Okay, the whole reason behind that is we don't want them swallowing kind of air because they did just have some pretty big surgery in this whole area. Okay. After barium swallow or our contrast dyes, talked about increasing fluids, drink lots of water. But is water going to help? Yes, but what's going to be better for these patients? 2 large bore IVs. Okay. To try to get this barium through the stool. When it passes through the stool, it'll turn the stool a chalky white. Okay. Surgery is not always the best option. Firstly, we want to try lifestyle modifications. So avoid your trigger foods. Keep your head in bed elevated 6 inches. Remain upright after eating. Weight loss is really, really important, especially for people that have a shorter stature and are overweight. All of that kind of weight gets in the stomach, the abdominal area. It increases abdominal pressure, which can kind of cause some more hernias. Okay. So now we're going to talk about our obesity, malnutrition, and short bowel syndrome. Okay. Alrighty. So for our malnutrition, it's important to note the types of enteral nutrition we can be giving to these patients. It's not important you memorize them word for word. It's kind of like just understanding the nursing considerations associated with it. When someone is on complete enteral nutrition, they will be receiving everything from this. This is usually your Javita, things like that. Okay. Modular, think macros, your proteins, carbs, and fats. Isotonic, This is going to help patients that have some tolerance issues. And then finally, hypertonic is good because what do we know lots of our laxatives do? Whether it be bulk forming or stool softeners, etc., they help pull fluid into the intestines to help move along the stool. So it's really important that if someone is on a hypertonic solution, that we're watching for signs and symptoms of dehydration and severe diarrhea. Okay. So those are your different types of feeds, okay? That's just a broad overview. Don't focus too much on that. I want you guys to understand these next two slides, okay? We really need to understand what in the world is the rate of feed. So really you have two different types. You have your bolus and your intermittent, okay? With your bolus, all this food is given at once, and it's usually given around 15 minutes. We need to make sure that not only we flush the tube before, but we also really need to flush the tube after and every 4 hours. Additionally, these patients just received a big meal very, very quickly. We have to keep the head of the bed up for about an hour to help aid in digestion. When someone is on an intermittent or a continuous feed, whenever this feed is going, the patient has to remain upright. Let's say for whatever reason you need to turn your patient onto their side. If they are on an intermittent or a continuous infusion, this is the highest risk for aspiration. Why? Well, when you're on a 15-minute bolus, you are a 15-minute aspiration risk, plus, 1 hour after and whatnot. If you're on an intermittent or continuous feed, you are a 12-hour aspiration risk. And that's what I really, really need you guys to understand. Okay, they always have to be in semi-full hours. If whatever reason the patient's blood pressure drops to 70/30 and you need to put them in Trendelenburg, what are you going to do? You're going to stop the feed. And that's what you need to know. Okay, always flush your tube before and after feedings. I have another slide in a bit that kind of goes over troubleshooting. Okay, when we're talking about types of equipment, just understand that these are various different types. You have your NG tube, your Dobhoff is very small, so I wouldn't recommend crushing lots of meds and putting it in the Dobhoff simply because it can clog. Dobhoffs usually are only used for enteral nutrition anyway. If someone has a tube that goes directly into the stomach, we really need to be watching for skin breakdown and kind of rotating that tube to make sure it doesn't, get stuck. Alrighty, so here's some of our troubleshooting that we as nurses are responsible for. What happens if the tube's not patent? Usually this actually happened to me last week. The tube's not patent. Some people put Coke, Pepsi, whatever in it. I can't talk. I don't know much about that part of it. But they actually do have toolkits that we can use to kind of help instill a solution into someone's D tube to kind of break up the clots. But what is the number one reasons tubes get occluded? Meds aren't crushed properly. So whenever we are crushing up our meds, we have to make sure we're thoroughly flushing after and that we really are doing our best to crush meds. So what does that mean? Well, we have to make sure our meds can be crushed to begin with. So kind of working with pharmacy, coordinating that way is super, super important. If your patient just had a new tube put in and their sutures involved, do not touch it. That is now a GI issue. They will come in, they will take care of it. Overfeeding is something we kind of need to be aware of, and really the best way to figure out is assessing your patient and checking for residual. Okay, aspiration pneumonia, we've talked about how we can kind of keep our patients safe, but in the event they do aspirate, you stop the feed, you suction them, you give them some oxygen, you get a set of vitals, and you call the provider. Refeeding syndrome is an issue when we essentially feed someone too fast who was pretty malnourished prior, that the body goes into a state of shock and it kind of forgets how to digest food and it starts catabolizing fat and protein, which can cause confusion, weakness, and seizures. some special considerations. The gold standard is going to be an x-ray, but in the meantime, we can either aspirate the stomach contents and do a pH test, or what you'll see a lot of nurses do is instill air into the NG tube and listen with their stethoscope to verify placement. Okay. Please verify with your pre-class worksheet, but usually with checking residuals, if it's between that like 150 to 200 area, we want to hold the feed if they have that much residual left, because that's telling me I gave them food and they haven't even digested it yet. Okay. We always flush the tube every 4 hours and before and after meals. Moving from the malnutrition portion, now we're going to head into the obesity part. Just know that there's different types of obesity. What we see most commonly is either our gynoid, which is a little bit of a pear shape, and our android, which is a little bit of an apple shape, okay? We talked a lot about hiatal hernias and GERD, but typically people that are obese that have more of this android figure will have more of those symptoms, because all of that extra weight is kind of pushing up on your internal organs, and that's why we see a lot of those symptoms in patients like that. So patients who are obese can undergo weight reduction, but there is surgery criteria. So you either have to have a BMI of over 40 with a history of unsuccessful weight loss attempts. Okay, usually over 40 they're going to advocate for this surgery. Or you can have a BMI of over 35, but you must have comorbidities. What are comorbidities? Well, they are pathologies associated with being overweight. We know that being overweight can put you at risk for hypertension, type 2 diabetes, heart failure, obstructive sleep apnea, hyperlipidemia, all of those things. So that's what we classify a comorbidity. So that can qualify you for surgery. Now, I really want you guys to remember there is also exclusion criteria. Okay, we've got surgery criteria that says, okay, way to go. Well, we've also got criteria that says absolutely not. So what is our exclusion criteria? Mental health and mental illness. We know that a lot of people tend to use food as a coping mechanism. So if someone has history of untreated anxiety, depression, bulimia, binge eating disorder, all the above, surgery is not going to be an option for them, because we're not treating this underlying issue that can really make their surgery unsuccessful. So if someone has any sort of psychiatric issues, we need to get that under control before we go do a weight loss surgery. We've got different types of bariatric surgery. It's not super important to note the different types. I have them here for you and your learning purposes. But just know that essentially what we're doing is we're shrinking the holding capacity of the stomach, or we are interfering with the absorption of things. But with our restrictive surgery and our gastric bypass surgery, they're good options. But if the patient continues to eat the amount of food that they ate before the surgery, eventually the stomach is going to grow back to the size. So yes, surgery is an option, but diet is the most important, because you can render the surgery unsuccessful if you just continue to eat. At first, it's going to be really painful and really hard, and it might make you really, really sick, but eventually the body adapts. So a lot of our complications include dumping syndrome. This is why we teach these patients to have a high protein, low fat diet, low carb diet. Why? Because carbs are sugar. So what happens with dumping syndrome is when we have way too much sugar that goes through the body way too quickly, you'll start to see a lot of these symptoms: diarrhea, dizziness, tachycardia, cooling, clammy skin right after eating a high sugar meal. It's really important after the procedure to maintain the patient's airway and monitor for a leak. This can happen, and we will start to see really bad back, shoulder, and abdominal pain with these patients. Again, we've talked about discussing emotions and coping skills. Remember, we've taken the size of someone's stomach and we've reduced it down to like this. Okay, so 6 small meals a day is really important for these patients. We want to make sure that while they are eating in a calorie deficit, that they are also getting in the nutrients they need. For example, they might tell these patients, okay, maybe eat 1600 calories a day or something like that. Well, 1600 calories of a balanced meal that incorporates, some lean chicken, some rice, some vegetables, some eggs, and some fruit is a lot different than 1600 calories of like 5 donuts. Do you guys get what I mean? So how do we check for, some malnutrition? We're gonna look at the albumin levels. Okay. Additionally, major abdominal surgery. So they will have an abdominal binder and make sure that they splint when they cough. Up next is short bowel syndrome. It's a little bit different from our obesity and malnutrition, but short bowel syndrome is a malabsorption issue. The body simply just has a really hard time absorbing like all the great things that food give our bodies. So this can make our patients really dehydrated, really malnourished. Okay. So all this food essentially goes straight through them, which is why they have a positive fecal fat test. Okay. Lots of complications, but I want you guys to really be thinking about dehydration, malnutrition. Okay. Additionally, these patients can have lots of vomiting, lots of heartburn. So who's at risk for short bowel syndrome? Lots of our Crohn's disease patients. Why? We know that Crohn's eats through all the layers and can eventually cause a malabsorption issue. And then cancer patients that have been receiving chemo and radiation, especially to the stomach area. Okay. What in the world are we going to do for medication treatment? We have to somehow help them get rid of some of the byproducts of food. So what we do is we can give them cholestyramine, which is a bile acid secretion, so that all this bile is not building up with their food. Please note that with cholestyramine, it must be taken with food. If you eat breakfast, lunch, and dinner, what are you having with breakfast, lunch, and dinner? You're having your cholestyramine. What if I have breakfast and I'm so busy I don't get time for lunch and then it's time for dinner? Should I take a cholestyramine at lunchtime? The answer is no. All it does, you take it with food so that the body can take this bile acid that's produced and help get it out. Okay. Talk a lot about diets. For these patients, a soluble fiber diet is the best. We really want to avoid insoluble fiber, which can be a little bit harsher on the stomach. And the human body already has a really hard time digesting insoluble fiber to begin with. What if you do that to a patient with a malabsorption issue already? Okay, not very fun. So your traditional brown rice, barley, green vegetables, your traditional like health foods might not be the best for these patients because there's going to be no way they're going to even begin to try to break that down. Okay. So moving along from GI, now we're really going to get into our connective tissue disorders. So up first, we have rheumatoid arthritis. Now, rheumatoid arthritis, what I want you guys to think about is this is a systemic autoimmune disorder. I've already drilled it into your heads what we need to know about autoimmune disorders, but this is total body. Therefore, we're going to have lots and lots of total body symptoms. So we're going to have this bilateral pain, bilateral swelling, joint deformities everywhere because my body is simply attacking my connective tissue. And that's what's happening. These patients will usually have a low-grade fever, just part of the pathology. Morning stiffness. Why? Because they haven't been moving all day and they wake up very, very, very stiff. So some of the lab values we'll see in these patients is that positive rheumatoid factor, things like that. So what are we going to do? We're going to treat the autoimmune issue. Okay. We talked about NSAIDs being pretty good for autoimmune sometimes. Prednisone's really good, methotrexate, Remicade. And then finally plasmapheresis to try to pull out some of the plasma with all those anti-rheumatoid like antibodies and whatnot. Okay. Activities that are really good for these patients is a chronic disease, so we want them to still keep moving, still keep exercising, stretch, do yoga. Swimming is really, really good because it's low impact. But it's going to be pretty painful for them to do these things, so have them take an anti-inflammatory beforehand. Good rule of thumb, if it's really, really stiff, we're going to give heat. If it's painful and inflamed, we're going to give ice. But we can alternate, okay? Finally, use large muscle groups for tasks. I know girls like to wear we like our concealer under our eyes to hide our really big bags under our eyes, and we usually use them kind of like with our little ring fingers. But let's say we had a woman with rheumatoid arthritis that wanted to kind of do the same things with their makeup. We're probably going to have them use like the back of their hand or something, simply because they need to be using larger muscle groups for tasks like that, because they're going to have a really hard time, especially with the joints and stuff, doing fine motor skills with our smaller muscle groups, if that makes sense. All right, and I really like this slide because it kind of goes over some other complications of rheumatoid arthritis. We've talked about they have lots of low-grade fever. We have increased C-reactive protein, increased ESR, that positive antibody. Usually these patients become very, very fatigued, so it's important that they rest in between different parts of the day. Chronic swelling, usually symmetrical, etc. Now we're talking about osteoarthritis. I want you to think normal wear and tear. So, you have your sports players or your individuals that work in trade that are doing the same jobs, that are using the same muscle groups, the same bones, the same joints. They're going to have wear and tear. So that's why usually you'll see it on one side of the body or in one select place. That was overused and overworked. It is simply wear and tear. Especially with the fingers, you might see your Herberton nodes and your Buchard's nodes. A good way you can remember this is your buccal nodes come before the Herberton nodes. Think Buchard, think before. Okay? Lots of pain and crepitus with range of motion. In the short term, we can use some NSAIDs. But if this is wear and tear, usually we're going to opt for surgical intervention such as an arthroplasty. But when these patients are experiencing lots of pain, we want them to rest, okay, and keep that joint in a functional position. And just review kind of some of your arthroplasty considerations, like your hip abductor pillows, all the sorts. So go ahead and review that. Up next, we have Lyme disease, which kind of can be classified as a little bit of a connective tissue disorder, because when we get to severe stages of Lyme disease, we actually have really bad arthritis and whatnot. So we know that Lyme disease is usually acquired from kind of camping, hunting, being outside, and you get a tick bite. Not every tick carries the disease, but usually our deer ticks infected with this B. burdifori can transmit the Lyme disease. So in that first stage, we'll see that bullseyes, rash, and flu-like signs and symptoms. In the second stage, you'll start seeing some early dissemination, some more psych stuff. And then finally in stage 3, they're going to have lots of arthritis and permanent nervous system damage. Unfortunately, it takes about 4 to 6 weeks to get tested for Lyme disease, but if patients present with that bullseyes rash, the symptoms, the history matches up, they went camping, we're usually going to prophylactically treat them. It's actually quite easy to treat Lyme disease. We just simply treat it with antibiotics, okay? A big focus of Lyme disease is simply going to be on prevention, making sure you're wearing light colors, long sleeves when you go outside, that when you come back, you are inspecting your clothes, your hair, your body for, to see if a tick latched on. And in the event that you do find a tick, you're going to remove it with tweezers, but you're not going to squeeze because we don't want that tick to transmit anything else. And DEET repellent is really, really cool. And I have just this slide for you guys to just, help reinforce some of the teaching points. So now we're going to talk about diseases that involve dietary management. When we have our celiac disease, this is an gluten sensitivity, but it's an autoimmune disorder. And unfortunately, the only treatment is to cut out all gluten for life. So what is our gluten? It is our wheat, it is our rye, it is our barley, beer, um, all of those are not good for celiac patients. And what's the big deal about, oh, well, they just once in a while, bread once in a while? Well, not really. The more gluten that these patients eat, it actually puts them at risk, increased risk for cancer. Additionally, a big thing with celiac disease is osteoporosis. So we really want to be teaching how to kind of get some bone density screenings, maybe some vitamin C supplements, vitamin D supplements, anything that can help. So, what foods do you avoid? Wheat and rye. And what are some of our safe foods? Cheese, eggs, butter, milk, veggies, fruits, all the sorts. Lactose intolerance, on the other hand, this is not a dairy allergy. It is an intolerance to lactose, meaning the body has a hard time breaking up lactose because it is missing lactase, the thing that breaks up lactose. Fortunately, though, this is treated pretty well because you can take it with lactase, a pill that helps break it up, and you will take that with food. Okay. We know our hallmark signs and symptoms of the bloating, gas, diarrhea, etc. Additionally, just to kind of put things in perspective, not every dairy product has lactose in it. And remember, this is not a dairy allergy. Things such as hard cheeses, Greek yogurts typically are lactose free, and it's pretty safe for these patients. However, ice cream, coffee creamer, heavy whipping cream, things like that, milk usually have lots of lactose in them. Okay. And now we have our foot disorders. So lots of different foot disorders we've kind of learned about, but just to kind of break everything up pretty simply, we're going to focus a lot more on what are our nursing interventions. Obviously, with our hallux valgus and our bunion, we're going to try to maybe get them some specialized shoes to make things a little bit more comfy. With our hammer toe, same thing. We're going to want to get some custom shoes made for these patients. Plantar fasciitis is a little bit more common kind of in the younger generation in our athletes because it's this inflamed arch, okay? Corns are different than calluses. I'm pretty sure everyone's gotten a callus before, but corns actually do require surgery to remove. We know lots about ingrown nails, and especially for our ingrown nails and our ingulavium issues, is think about your diabetic patients that have a really hard time not only healing their feet, but feeling their feet. What about our peripheral artery disease patients? Their feet aren't going to heal quickly, which is why foot disorders are a really big problem. Especially ingrown nails, our type 2 diabetics might not even feel pain. They might not even know that they have an ingrown toenail, and then all of a sudden, their foot looks like the bottom, and then they need their toe completely amputated. So it's important to kind of teach that proper foot care. So please review that. Lots of different treatments for our bunions. You can use a bunionectomy, but this is a pretty hefty recovery time where they do have to be non-weight bearing. For plantar fasciitis, again, we can get some specialized shoes, some NSAIDs, some steroids, anything to help out with the inflammation. Remember, heat and inflammation, we're going to give some ice, okay? Big rule of thumb when we're talking about foot disorders is that they do take a really, really long time to heal because that is the furthest point away from kind of the heart and the supply of blood flow. Okay, especially in our older adults that have other comorbidities, healing can take quite a long time. Gout, we kind of also sort of classify as a little bit of a foot disorder, but what's going on with gout is essentially my body has a really, really hard time breaking down uric acid. So I have this big buildup of uric acid that can actually form crystals, which can lodge in our usually in the greater toe, and that's why we kind of do classify it a little bit as a foot disorder. But with gout, we can treat with medications, but what where does uric acid come from? It comes from the breakdown of purines. So naturally, we want to avoid high purine foods, and we'll talk about it. We have a couple different stages of gout. Usually we have this gout attack in our big toe, and then we also have this tophaceous phase. This is when people kind of chronically have it for years, usually common in our patients with chronic renal failure, things like that. But they can also have uric deposits under the skin, and you'll kind of see these white little patches, this white grayish little patches under the skin. So what are we going to do? Well, we can give allopurinol, which is our drug of choice. Again, with allopurinol, you really need to take it with or after meals. Okay. But what's the best thing we can do? We can avoid those high purine foods, our charcuterie board, our fancy foods, our organ meats, shellfish, sardines. We know that alcohol and caffeine and red meat also are really high in purines. Another thing we can do, increase water, because if we increase my water, it's going to kind of help flush out some of this uric acid that is being built up. Also, remember, lots of our diuretics can increase purine levels, and then aspirin, really, really bad because it's got this purines in it. Okay. And last but certainly not least, we have our bone disorders. So, just a few key terms. We've got our osteomalacia. I want you to think of softening. Okay. Usually due to decreased vitamin D. Osteopenia, this is how we categorize someone who has low bone mineral density for their age and gender. Osteoporosis is an actual condition, also known as our brittle bone disease. Okay? So, what in the world is osteoporosis? Again, usually our silent disease. We have an imbalance of blasts and clasts, if you will, but it eventually kind of causes the person's bones to kind of become really, really brittle over time, which can contribute to this kyphosis, lordosis, things like that. Postmenopausal women are at huge risk for osteoporosis because they do have some calcium issues and some bone reabsorption issues as well. How do we diagnose osteoporosis? We look at our T-scores, okay? If someone is usually less than 2.5, it means that they do have osteoporosis. So I focus more on your T-scores. Also, it's important we do frequently monitor these patients' calcium levels. So what can we do? We can give them some calcitonin. This really, really helps decrease bones being reabsorbed. Calcium with vitamin D, also really good drug of choice, are allogenate, Fosamax. This really helps, but it must be taken in the morning on an empty stomach. Okay. Please, please, please review your pre-op and post-op checklists of a hip joint repair or a vertebroplasty. And now we have our chronic pain, also known as our fibromyalgia syndrome. So this is a chronic pain issue, but it's not an inflammatory. It's not because someone's swelling somewhere and it's releasing the pain receptors and all of that along the inflammatory pathways. It's linked to neurodysfunction. There's a couple of different risk factors: stress, alcohol, no sleep, viral infections, things like that can put someone at risk for fibromyalgia syndrome. But unfortunately, we don't know too much about this. So diagnostic wise, we just rule out everything else. These patients usually have trigger points that are very, very predictable, usually on the neck, trunk, extremities, and back. Additionally, they have some blurry vision, dry eyes, and problems concentrating. What can we do for fibromyalgia syndrome? A lot of the medications we give, and I'm not sure if you've learned about them in pharmacology yet, but a lot of it's just going to be neuropsychiatric medications. Okay. Amitriptyline, pregabalin, duloxetine, tramadol, cyclobenzaprine, tizanidine, all of these act on more the neuro pathway of things because this is neuro dysfunction. Okay. Because there's so little known about kind of like the cause and research is still ongoing, we actually do advocate for some complementary and alternative medication, such as guided imagery, deep breathing, acupuncture, because all of that can really, really help these patients because we don't have like a definitive medical treatment. We can give them some neuro medications, but at the end of the day, we're still kind of learning and working through it. Low impact aerobic exercise is really helpful for these patients, especially you never want to tell a patient, oh, just don't exercise ever again. You just kind of have to modify it a little bit. And then you'll hear me say this a lot, but alcohol and caffeine are really, really, really big triggers for a lot of our GI issues, a lot of our cardiac issues, a lot of, even this pain issue. So it's almost always avoid caffeine.